So that is why I say that when we have these complex cases, these are 2% of our entire clientele of CNVMs, when they present to us, we should not shy away from a referral, because otherwise we end up burning our fingers with these cases. I think for the paucity of time, I'll invite the next speaker. I'll like to introduce Professor Harsh Lanka. He is from INHS Ashwini, and he'll be speaking to us today about CSCR.
Thank you, sir, and good morning to the audience. I'll be presenting on behalf of my colleague regarding certain series of cases of actually not CSCR but subretinal fluid spectrum of cases. So this is a standard classical CSCR and various modalities of imaging. Just to recapitulate what we are dealing with. So first of all, we talk of a case in which a 31-year-old young person, which 3 to 4 week of history of blurred vision, was treated with TS substitutes as computer vision syndrome, MGD, and that kind of spectrum of disorders. However, later on, it's only during his fourth visit that his fundus was evaluated, and this was the picture. Now this is the standard young person presenting with subtle diminution of vision and metamorphopsia, CSR. But why did we present this case? Because fundus was not seen in this case. It's only on third or fourth visit the patient is actually being seen. Even non-mydriatic fundus was not seen in this case. So later on, he was we took help from our psychiatric colleagues, and he was managed as a case of CSR. Moving on. So now there is a other spectrum of cases in which it may not be CSR, but it is being treated just as CSR because there is some subretinal fluid. So in this case, we have a 23-year-old lady presenting it again, subtle definition of vision in unilaterally. And since the vision was okay, she was just being corrected with minor correction in spectacles. And only later again also in these cases was the fundus seen. And here we see this picture, and therefore toxoplasma was assay was done, and later on it was proven and it treated with clindamycin or Ozurdex. So again, akin to previous case, fundus evaluation is done only during later visits, just because she was young. Again, we have a 22-year-old lady presenting with color vision deformity during her screening evaluation for occupational entry to a professional course. In this case, screening for military recruitment, wherein she was found to have color vision defect. And when the fundus was seen, this was the picture. And based on the morphology, we can see the RPE defects, and this was diagnosed as a case of cone dystrophy. And later on, she was counseled, because in future she needs to bear kids and what is the prognosis of children and all. And of course, she was counseled on preserving her sight using UV protection. Again, a 16-year-old girl who was aspiring competitive swimmer, who presented with moderate diminution of vision in one eye and treated as anterior uveitis with unexplained vision loss, and then again found to have inflammatory cause, and later on it was found out that it was a CNVM and not just a subretinal fluid of some cause. So what was missed in all three cases was the fact that they were young ladies and not men. So it is seen that this simple fact is being forgotten by people who are forgetting the epidemiology of CSCR, that it is only men who are generally predisposed to these cases, and also that even in subtle diminution of cases, in cases with subtle diminution of vision, the ophthalmologist should insist on carrying out color vision checks and contrast sensitivity and non-mydriatic fundus examination. Even in a busy OPD, if the patient is coming for the second time and the patient is worried regarding the symptoms, This should prompt us to consider these tests. Then we have a case of diabetic, who is a young diabetic presenting with subretinal fluid, and we have a OCT scan in this person in different machines. This is the picture which is shown in Cirrus 5000, and here we see the inner retinal thickness to be that is CMT to be 155 microns. Whereas if we move to spectralis, it gives a reading of 385. Now if we just rely on technicians who write on without seeing the photograph, we will just rely on technicians who may just give us the CMT and go ahead with it and tend to prognosticate this case, we may fall into a trap. So this is because of segmentation error in this case. Whereas wide field OCT gives us a more reliable picture in this case. So what is this we are dealing with? So further angiography and FAF picture gives us there is a hyperfluorescence leakage along the superiotemporal arcade, prompting us that there may be something else, and there is fluid tracking sign. So there is CSCR as well coexisting in this patient who is status post PRP. So this is not just because of the diabetic changes, this is a CSCR in a coexisting in a diabetic. What about this kind of picture in which we are treating the patient as a case of CSR and we find this hyperreflectivity in the intraretinally? So this is to be taken cognizance of, and we can see there are two strata of fluids. One is SRF, one is below the RP. So this is prompting us to consider other diagnoses such as CNVM. So just because somebody is diagnosed as CSCR, should we not do OCT in every follow-up, that is when we call them for monthly or 3-monthly reviews? The answer is no. We should actually do the OCT every time a patient is visiting us, because some surprise may be lying. Because all said and done, CSCR does also have about 4 to 5% chance of developing CNVMs. Though the clinical clue of developing CNVM such as hemorrhage is very evident, but then by the time the patient is presenting with hemorrhage, it's quite late, and we would rather diagnose it early if the CNV is existing and treat it at the right time. So the OCT clues are important, such as the ones we discussed, which includes intraretinal fluid, any segmentation, and any choroidal thickness associations. We know that in CSCR the choroidal thickness is more compared to other disorders. And also, if there is any occurrence of new hyperfluorescences, as this photo demonstrates, we should also consider CNVM, because we should not confuse this with multifocal CSR, because there may be CNVM happening simultaneously in these cases. So the take-home messages is, in this spectrum of people, of young people presented with subtle diminution of vision and metamorphopsia, we should consider doing color vision and other macular tests such as contrast sensitivity and photo stress test. Fundus evaluation, even if good visual acuity of 6/9 or 6/6 parts is present, we should insist on it, even if in a non-mydriatic setting. Gender should be in our mind, that females are generally not predisposed to CSR, and we should look for OCT clues and acquire scans during reviews. Laterality is also important. If somebody presenting with bilateral symptoms, we should consider systemic conditions or any dystrophies. And all in all, we should summarize it by thinking that SRF in all young individuals is not always CSR. I conclude. Any questions or remarks, please?
I think we'll skip the questions and continue to the next speaker.
Thank you.
The next speaker is Colonel Pradeep Kumar. He's talking about MACTELs.
A very good morning again. So, talking about macular telangiectasia, this is an entity which was not very well known about 2 to 3 decades back, but it has now sprung up with the origin of multimodal imaging. So, this is the classical case where we see perifoveal change in discolorations may be associated with some amount of pigmentation, and these discrete white discolorations are the beginning of the disease. Now coming to the FFA, how it proceeds, as we look over a period of time, one can see that in the perifoveal region, now we are seeing appearance of these very discrete hyperfluorescences which are not increasing in size over a period of time. So this is what a classical case looks like, and they have these right angle dipping vessels. We have reported this, and they are hypoautofluorescent which are corresponding to the PEDs when they are associated with macular telangiectasia type 2. Here we can see these classical right angle dipping vessels, and the diagnosis becomes difficult when we have macular telangiectasia occurring in this concurrence with other diseases and other masqueraders which do look like MACTEL. And lastly, any case of macular telangiectasia you have to keep under follow because they can throw a secondary CNVM at any stage. So again, as we say, don't miss the two very similar looking diseases. So it can present with PEDs. Now coming to this particular case, we can see that there are perifoveal telangiectasias in the images on top, and they are associated with these PEDs on the OCT. The classic pointer is the intraretinal cavitation that we see, which gives us a clue that yes, this might be a case of macular telangiectasia. And the catch occurs when we are seeing the OCT angiography and going to the deep capillary plexus. This is the part of OCTA which we should be analyzing carefully to look for the changes of macular telangiectasia. Now it can be associated with secondary CNVMs. Now in this particular slide we can see the feature A shows a very thin layer of hemorrhage, and along that hemorrhage we can see a disc shaped area which is greenish to yellowish in color. Now this is what gives us a clue that even on a detailed fundoscopy we could have examined that some change towards CNVM has occurred in this pre-existing case of macular telangiectasia on follow-up. Now when we look at this enlarged image, the diagnosis can become clear even in an OPD without resorting to any of the investigations. And as rightly pointed out by one of our audience, even if you do not have access to these multimodal imaging investigation, you can go ahead and treat these cases clinically. Now it can also be associated with polypoidal choroidal vasculopathy. We have reported that macular telangiectasia is associated with PPK choroid, and in this particular case we can see that the STOCT which passed through a polyp-like membrane, and while on the lowermost OCT we saw this intraretinal pigment plaque. So while the intraretinal pigment plaque is pointing towards macular telangiectasia, in the scan B we can see something which is now looking like a PCV case. So now we take up a simultaneous FFA and ICGA, and the mystery is resolved. The polyp becomes quite clear, and we treated this case and the vision was restored happily. Now foveal cavitations in MACTEL have to be balanced against what is happening elsewhere in the entire macula. Now the blue pointers, they show you a small area where a subretinal fluid accumulation has occurred in the area around the disc, while this kind of intraretinal cavitation looking like a very sweet heart is also apparent. Now this is the case where we have a central serous chorioretinopathy which is occurring in a pre-existing case of macular telangiectasia, as can be seen quite obviously that right over the papillomacular bundle we had this case. Now this is another case of CSC with macular telangiectasia. this is what prompted us to look into the spectrum of pachychoroid in Mactel. We have reported it twice, and we have been able to elucidate that pachychoroid is also associated with macular telangiectasia. Now, coming to CSC with Mactel, what one has to be careful of is not to misdiagnose the subretinal fluid as a marker of a CNVM. So, this is a sub-RPE fluid with an intraretinal cavitation without any subretinal fluid. So, should not be treated as a CNV by somebody who's just looking for a hint of fluid anywhere on the OCT. So, not all fluid on an OCT needs to be treated, and sometimes the lesion may not be macular telangiectasia at all. So, now looking at this particular image, one might be prompted to think that yes, I have something underneath the retina, it is associated with some form of fluid, probably this is subretinal fluid and I should treat. But no, in this kind of image one has to think in terms of AOFVD also. Now, this kind of outer retinal cavitations have again been reported in 2017, and this is a case of solar retinopathy. So, whenever you see these dark spaces in an OCT, need not go for the anti-VEGF option directly. Now, further fluid spaces in the retina can occur because of varied causes like acquired retinoschisis, and these acquired retinoschisis can lead to confusion with the diagnosis of macular edema and subretinal fluid. Now, coming to the associations, that this kind of fluid spaces may not be solitary at all, and what we have to look for is the peripheral retina, and sometimes we can pick up diseases like FEVR, so to find out why the disease has occurred. And lastly, we have to look at the choroid and retina junction carefully. I'll summarize by talking about these drusen's which are even being diagnosed as inflammatory or CNVM cause and being treated with intravitreal steroid and anti-VEGF, which we do not feel should be the ideal approach. These giant drusen's were reported by my very dear colleague Dr. Vinod recently, and these are just plain simple vascular shadows and should not be confused for any fluid. The mirror image pattern on an OCT should be alerted for, and one should not confuse these for occurrence of detachment or fluid. So, what determines the clinical output of an OCT is the correct indication, an observant eye, and knowledge of the interpretation which we see. And lastly, carry on with the Gauss method, that whenever you are not able to append the diagnosis to a particular scenario, keep it in a file, let it simmer for another 3-6 months, collect 5-6 such new cases, and probably you will be able to report a new disease entity. Thank you so much.